uterus, or in this case, outside the uterine lining itself. Because in a case where endometrial tissue is growing into the myometrium, while we call that adenomyosis, in technicality, that would be a spectrum of endometriosis, because endometrial tissue is growing into the myometrium. Now, this abnormal endometrial tissue can occur anywhere: ovaries, fallopian tubes, outer uterus, pelvic region. There has also even been documented cases of thoracic endometriosis within the pleura. So it's quite an intense disease. So right there is a histologic image with an endometrial gland and a lot of endometrial stroma. So observation of such histopathologically in a biopsy tissue outside the endometrium is what is diagnostic of endometriosis. So I have just a small illustration I did really quick of signs that we may expect endometriosis routinely. I'll start with number one. So this just, it's more but one dimension of view, because I didn't quite have the time. Oh, I also forgot to mention I'm an amateur medical illustrator. So the first one is adenomyosis, because that is the uterus. We can see endometrial tissue. Endometrial tissue growing into the uterus. The second one is ovarian endometriosis, or what we commonly refer as endometrioma. The third one is superficial or peritoneal. And then the fourth one is deep. That is within the posterior compartment. There's also one somewhere along the bladder, that is the anterior compartment. So we divide endometriosis into superficial endometriosis, ovarian, deep infiltrating, and now what I mentioned, adenomyosis. But adenomyosis is routinely discussed as its own entity. Now, your sonographic procedure. Before we proceed to the ultrasound procedure, the International Deep Endometriosis Analysis Committee that contains radiologists, it contains minimally invasive laparoscopic surgeons, gynecologic, sonologists, clinicians. They developed a certain ultrasound procedure that improves detection of endometriosis in patients. So, some of the slides that I'm going to present here are picked up from the recommended ultrasound procedure by the IDEA. And these are some of the recommendations that they have made to optimize your sonographic procedure in case you're suspecting endometriosis. The first one, these are the pre-procedure steps that I'm assuming we all do when we are performing transvaginal ultrasounds. Standard including consent, including infection prevention control, and the bladder should be empty. The second one is patient positioning, which is one actually of the most limiting factors when you're performing transvaginal ultrasounds. The patient should be positioned with hips and knees flexed, legs separated, and a wedged cushion placed under their sacrum for comfort. Now, the position should be in lithotomy position, kind of the position we perform hysterosalpingograms. The patient should slide down to the edge of the couch. First, this enables you to have space for dynamic probe movement. Secondly, this will limit or will reduce strain on your shoulder. Again, these are procedures that we do for many years. So routinely, patient comfort and your own comfort will help improve your work quality. And then lastly, there is a certain technique that is being introduced into the field called sonovaginography that involves injecting gel to the posterior vaginal fornix that enhances detection of deep endometriosis. It's kind of like stepping up the way we do with superficial nodules, where you apply a lot of gel to step up the probe and improve visualization. So this is a new technique that is coming up. Now, these are the basic steps that have been recommended. The first step, you're supposed to evaluate the uterus and adenexa. In this step, you're supposed to rule out presence of adenomyosis and ovarian endometriosis, that is endometrioma. Then the second step, you're supposed to evaluate for soft markers, that is site-specific tenderness. The patient will describe tenderness to probe compression. And then you also evaluate ovarian mobility. Remember earlier I stated that endometriosis has been a major cause of severe pelvic conditions. So in such a case, ovarian mobility will be limited. Essentially, the ovaries are supposed to be mobile within the pelvis. Not mobile in the sense that they can prolapse, but mobile in the sense that they should not be stuck in one anatomical location. Then the third step will involve assessing the pouch of Douglas for something we call the sliding sign. Later in the slides I have a video that shows what a positive sliding sign and what a negative sliding sign is. Now, this is also a test of mobility, because per se, the uterus and the rectum posteriorly do not attach to each other. Therefore, if you press with your ultrasound probe, the uterus should be able to slide past the rectum and back within the pouch of Douglas. This can also be enhanced in a case where the patient has some free fluid within the pelvis, whether physiologic or sometimes some of the gynecologists have been introducing the fluid themselves in the procedure that we use for HSGs. If the fallopian tubes are patent, we can introduce the fluid. Then the last step is assessment for deep endometriosis nodules in anterior and posterior compartments. So every one of these steps will guide you. For example, in the third step, if the sliding sign is negative, if the uterus does not slide beyond the rectum and back, if the pouch of Douglas is obliterated, more likely in the fourth step you're going to find nodules. If in the third step it is positive, that the uterus slides across the rectum, then it is unlikely in the fourth step that there will be deep endometriosis nodules. Now the whole point of all this is to be able to first assist the patient before they proceed to theatre, because this will help us rule out unnecessary surgeries. Because if an ultrasound is performed correctly, we should have a confidence of more than 70%. It's kind of like how we classify masses in birads, tirads, that prevents us from doing unnecessary FNAs and biopsies. So it's a proposed system that is similar. Now, we start with uterine adenomyosis. I'm not really going to pay much attention to this because this is a bit of a common pathology, sonographic pathology, but essentially adenomyosis is presence of endometrial tissue in the myometrium. The sonographic findings will be echogenic linear striations that are subendometrial. It causes a sign that we call Venetian blind, kind of like those blinds used with the ceiling, with the curtains. Irregular endometrial myometrial junction, or undefined, or one that is not definitive. Tiny subendometrial cyst, myometrial bulkiness, focal, diffuse. Focal could be diffuse, and then asymmetry. Then lastly, increased vascularity. So in the image that I have attached to my slide, I think I have captured most of the sonographic findings. You have the subendometrial cyst. You can see that the anterior, you can see that one, the endometrial boundary with the myometrium is very irregular. You cannot really define. There's Venetian blind sign, those lines that you see hypoechogenic. There's the lines that extend, that is the Venetian blind sign. Notice that this can also be a sign in the presence of fibroids. So actually 50% of adenomyosis will coexist with fibroids. So that is an imaging pitfall actually. And then lastly, you can see both myometrial walls are asymmetric. One is very thickened in comparison to the other one. Now, in the sonographic study where you find adenomyosis, 20% of those patients are going to have endometriosis. So this is the point. This is why I insisted on presenting adenomyosis during my study for endometriosis. Because if you find adenomyosis, the next step for you would be using the soft markers, going ahead and trying to test for them. Positive sliding sign where you press down on the cervix and observing the uterus slides across. If that is negative, then you move further and look for the nodules. Now, what about an endometrioma? So this is the presence of endometrial tissue within the ovary. Endometriomas can also be non-ovarian. because they can also involve the broad ligaments. Those are the ligaments that normally hold the fallopian tubes. They extend laterally from the uterus, then extend towards the ovary. But 75% of them involve the ovary. We routinely call them chocolate cysts because the appearance of their contents have a certain appearance that is chocolate-like due to hemorrhage. So in this case, on my sonogram that I have attached, this one is an it's an ovarian endometrioma. Notice that we said an endometrioma can also be an ovarian. It doesn't have to necessarily be ovarian. How we know that it is ovarian? There is a residual ovarian tissue towards the left, pointed by the two arrows. You can see a few follicles. So in an instance where you find an endometrioma in the ovary separately, that is not an ovarian endometrioma. So terminology is also very, very important. Now, when you find an endometrioma, because endometriomas have their typical sonographic features, avascular, intraocular, low-level internal echoes, just typically as demonstrated there. So, 25% of those patients are likely going to have deep endometriosis. So in an instance where you find endometrioma, again we are going back to our sonographic steps when we are evaluating for the patients, when we are evaluating the patient's symptoms. So when we find an endometrioma, it is recommended that we proceed further and use the previous steps stated to test for other signs of deep endometriosis. So endometriomas occur in about 10% of the women of reproductive age. So a quarter of them are going to have deep endometriosis. So in comparison to adenomyosis, the coexistence of this one and deep endometriosis is less. Now we can proceed to what you have been mentioning too much, deep endometriosis. So deep endometriosis is endometriosis that involves the anterior compartment and the posterior. Anterior having the bladder and the anterior serosum of the uterus. Then posterior you have the rectum and the uterosacral ligaments that link the uterus to the sacrum. So the definition, deep endometriosis is endometrial tissue growing deep into the abdomen and the pelvis. So as we have stated, an anterior compartment will contain the bladder, the vesicoureterian space, especially in patients who've had cesarean section done. They have a risk of having endometriosis within the anterior compartment because when they approach the surgery, they approach via that route. So there can be deposition of endometrial tissue during the surgery that can later result into endometriosis. And then also ureters insert along that route. So endometriosis that involves the ureters will be in the anterior compartment. Now, if it does involve ureters, it is very important to assess the kidneys because often there will be obstruction that will lead to hydronephrosis. So those are some of the correlations that are possible. The posterior compartment has the rectosigmoid colon, as seen. You have the pouch of Douglas, uterosacral ligament, and then a posterior vaginal wall. All those are potential sites of infection. So what are the sonographic findings that will help you suspect deep endometriosis? Now remember, in this case, as much as we are saying we are the feature gold standard, in the end, right now, what we have are features of. Very few cases can you find an actual endometriotic nodule. But often when we find features of endometriosis, we either have the patient go for a pelvic MRI or they go for diagnostic laparoscopy, depending on the severity of the symptoms and how the patient is clinically. So the whole point of all this is if you have features of, we know where to go next. If we do not have features of, we manage conservatively. So what are the sonographic findings? One, the sliding sign will be negative. The next slide has a video that shows that. So if the sliding sign is negative, where we say you press on the uterus and notice if it is sliding across the pouch of Douglas. If it is negative, it has an accuracy of greater than 90%. That all those cases, most cases, almost more than 90% of the cases will have a 90% negative sliding sign. So we have a negative sliding sign, which means if we can definitely rule this out. We are able to just remain with about 1 in every 10 patients who could have endometriosis and we do not know about it. So the sliding sign is very important. The second one is ovarian mobility, as we said earlier. The third one is question mark sign. So mostly this question mark sign can also be seen in transabdominal ultrasound. What happens is when you have an anteverted uterus, normally it appears in, not exactly as that image, but I know the sonographers have the image of an anteverted uterus in mind, how it appears just along the bladder. So in a case where there is endometriosis, it gets pulled down. It gets pulled caudally, that gives an appearance that looks like a question mark. There's an image that follows. And then lastly, you evaluate the ureters and kidneys. Remember we said that if we have ureteric endometriosis, we are going to have obstruction, definite hydronephrosis. So these are some of the factors that will guide you into suspecting deep endo. Now, what are some of the pitfalls? Prior surgery or infection can cause these adhesions. So, if the patient has had pelvic surgery, including cesarean section, if the patient has had pelvic infection, especially PID, these ones can cause adhesions that can cause a negative sliding sign. Because in the end, adhesions can result from a lot of etiologies. So this is one of the pitfalls. So you have to take your history very, very carefully. Luckily for us, endometriosis will have a history of cyclical pain. So that is one way to rule that out. And then secondly, you should be able to rule out prior surgery by obvious means. Then pelvic masses, the fibroids and endometrioma, these ones can limit visualization, especially fibroids, they make visualizing adenomyosis sometimes very difficult. So this is one pitfall that we need to overcome, and in a case where you are uncertain, MRI has a better detection rate than ultrasound. Then we also are encouraged to increase depth and increase the frequency to improve resolution. This enables you to capture deeper nodules or capture deeper involvement of organs. Then lastly, the last one is more of a tip, that if you are able to pick up a nodule and say that the nodule is within the anterior compartment or within the posterior compartment, that is actually very clinically helpful. Besides just writing your report that features are suggestive of, then say you get lucky, especially if you find free fluid within a pouch of Douglas, because this improves detection very, very much. So in a case where you tell the clinician that it is within the anterior or posterior compartment, this is very clinically helpful. I'll give you an instance. For example, if the nodule does involve the ureters or the bladder, and there is definite hydronephrosis on the ultrasound, that surgery will need to have a urologist, because the gynecologist's scope does not extend beyond the urogenital system. If the nodule is noted to involve the rectum, that surgery may need to involve a colorectal surgery. So some of the gynecologists that we work with will encourage you to, as much as this is a very big conversation, definitely if you're able to differentiate the two, that will improve the management in a lot of ways. Now, just to demonstrate what, so the first video that is playing right now, that is what we are talking about, the sliding side, where if you press down with your probe, the uterus is able to slide across the pouch of Douglas. But what about a negative sliding sign? Let's play one. So that is a negative one, where even if you press, the uterus does not slide across. So that one has a 90% accuracy. If that one is present in your study, there is a 90% chance that that patient will have endometriosis, while ruling out all the other causes of adhesions like surgeries and previous or prior infections. Now, on this far left corner, the lower corner, this is what we call the question mark sign, where this is an anteverted uterus. Now, routinely it would face up, but due to adhesions and a possible nodule down there, it is pulled down, and you can see the endometrium forms some form of question mark. That is a question mark sign. It's also very, very specific to endometriosis. There's actually no other condition that causes this. It has been written in literature as a very, very important sign when you're looking for endometriosis. Now, the same thing can be seen in a transabdominal ultrasound, where now your uterus will appear facing up routinely, and then at the fundus it curves down, forming the same question mark sign. Now, actual endometriosis nodules will look like the image at the corner. So, first of all, defining anatomy when you're doing your study is as important as it is during other ultrasounds. You have to first determine your anatomical landmarks. You determine your uterus, you determine your cervix, you determine your pouch of Douglas. If you see the pouch of Douglas, you know that posterior to that will be the rectum. Therefore, present negative sliding sign and then presence of a similar nodule. That is what an endometriosis nodule looks like. Same thing happens when it is anterior. So I think among the important things when it comes to these studies is defining your anatomy. Proceeding to the next slide, I want to talk about site-specific evaluation. Now, this is a case where the patient reports tenderness at certain sites. The first one is actually one of my images. I have published that case on Wikipedia. It's a cesarean scar endometriosis. This patient presented with she's a 40-year-old female who presented with a history of cesarean delivery about 7 years ago. Presented with pain at the site of the scar and a palpable swelling. The scar was not hypertrophic itself, but below the scar there was a palpable swelling. Now, when we did our study, this was what we found. It was an irregular mass. It was hypervascular. On radiopedia, you can find more images if you're interested that showed vascularity, including pulse wave. So the mass that was seen was anterior to the bladder, as you can see. There were a few calcifications. It was not necessarily homogeneous in the pattern. Well, presence of such a mass below a cesarean scar is very, very, very suggestive of cesarean scar endometriosis. Because as I had said earlier, the route they approach when they are doing delivery is just around there. Therefore, during closure, there can be deposition of endometrial tissue that later grows into endometriosis. So this one was later pathologically proven to be cesarean scar endometriosis when they did an excision of biopsy. And also the patient reported cyclical pain, which further assisted us in getting more confidence during the diagnosis. So overall, cesarean scar endometriosis can be located in the skin, subcutaneous tissue, rectus sheath or muscle, those are the anterior abdominal wall muscles, intraperitoneally or within the uterine myometrium that is related to cesarean section. So it is along that route, anywhere along that route. Now, for ultrasound, our role essentially is being able to detect such a mass, quantifying, giving the size of the mass, describing the vascularity, ruling out involvement to the bladder, because in this case you can notice that the anterior bladder wall is involved, and describing all your findings. Now the incidence of this is about 0.03 to 0.6%. So it's not quite a pandemic. Not many patients who undergo cesarean section will have cesarean scar endometriosis, but it is still a very good differential for you to have in mind when you are approaching such a pelvic mass. Because I understand this can be a diagnostic dilemma for you if this has not been in your mind. Because essentially, right, there are not many differentials that you can have, except maybe urethrocarcinoma or GI, I think, and maybe sarcomas involving the anterior abdominal wall muscle. Now, the patient will complain of tenderness and raised hypertrophic scar. Cyclical pain will be 70% of the patients. That is pain during menses because this is the endometrial tissue. Therefore, anytime the patient is having their menstrual period, the mass will be active, and therefore there will be cyclical pain. The nodule will have irregular borders. It is hypoechoic, as you can see, and may have internal vascularity. Now, the second one of site-specific evaluation is an umbilical endometriosis. Now, this is a bit more common than cesarean scar endometriosis. I'm certain most of us who have done ultrasounds have encountered several of these. I think myself I've seen like 5 cases of umbilical endometriosis. So the patient presents with cyclical bleeding and pain. at their umbilicus. When you examine, there's a dark brown nodule just above the umbilicus. You can use step-off to enhance your image quality. Now, while the image is censored, the image right there at the lower right corner is supposed to be one of the nodule. We call it villus nodule, the umbilical endometriosis. Dark brown professionally report they get their menses at that area. That is what you will find, very irregular. There will be vascularity. It's important to describe the size and describe the extent. That is the depth of the nodule. Okay. Now, a good differential for umbilical endometriosis is something we call it's called a system. Who knows the system? Who knows the system? There is something nodule. Sister? Yes, Sister Mary Joseph nodule. It's a metastasis due to abdominal or pelvic malignancy that deposits to the umbilicus. The difference is your patient will have an abdominal malignancy. Could be colorectal, could be something, but it's important to use history to differentiate the two. So these are my conclusions. Now, ultrasound has been proven to have a sensitivity of about 79% to endometriosis. This was proven just about 2 years ago by Leonardi. Leonardi is one of the professors in gynecology. He's Canadian. He's very active right now in the talk about endometriosis. So they have proven that 79% of an ultrasound done right and with practice that you can actually detect endo. So given the role of TBS as the first imaging modality for gynecological conditions, it is inevitable that we, the sonographers, will play key role in endometriosis diagnosis in the future. So now what can we do so that we get better at this? What can we do so that we stay relevant or so that we help the patient? First, we can have specialized training, workshops, certified programs, case reviews. These are actually present in the country. Third Park Hospital has been organizing several of them, but now unfortunately they train gynecologists mostly and sonologists, those physicians who do their own ultrasounds. So I feel like the society can I don't know, talk to that Park Hospital and see how they can train a few of our sonographers who can further train other sonographers in this, because in the end, all we want is to assist the patient. So if we improve our skills and we can be able to do better ultrasounds, then definitely the outcome will be better for the patient. Continuing medical education, like what we are having here today, collaboration with experienced gynecologists and radiologists, case in point, Third Park Hospital, some doctors, Dr. Jagi, Dr. Yamal, they are very prominent and internationally recognized people in endometriosis ultrasound. And then quality assurance programs, these are hospital-based, departmental-based programs that define how you approach your pelvic ultrasounds. Because as much as every sonographer does their ultrasound in their own unique way, in the end, having quality assurance programs, it will definitely improve the outcome that we determine the standard approach to each and every study. Now, those are some of my references. I'll just skip that real quick and go to my last slide. So that has been all. I'm hoping we get to have this conversation a little more at a later time. Thank you.
Thank you, Mr. David. And we appreciate your teachers ensuring that you always keep time. At this point, we're going to take questions. I think we'll take about 5. We're going to take all of them at once so that you answer. Any question, comment, concern? Quiet means that you're sleeping, you've understood everything, the teacher was boring, or is the best you've ever had?
Thank you for the wonderful presentation. Maybe for you to pass for us maybe information regarding your publication, which you've told us you did a publication. So if you would mind sharing with us, maybe where we can actually get the publication you made.
was taking the questions first. Let me just.
On some dates, lately we have a lot of litigations. What is your take on the issues of having chaperones on the new TPS? And the issue of male sonographers also doing it already. So maybe give us your opinion on that.
Any question? We are also having online attendance. Kindly online, you can send your questions, we'll be reading them maybe later on or immediately they get in.
Well, me, I don't have a question, but my recommendation is the citations you used in the presentation mostly is from these the so-called first world countries. But we would request if in case in our field of operation you meet such a case, because it's so hard to meet them in Africa, specifically Kenya, please be using it as a case study so that we can learn. And in case we have such a conference, we seek consent from such cases, and then we have specific rooms that we can use to learn and do it practically. And practice it in Africa, specifically Kenya, and help our society. That's my recommendation.
Those are 3 questions, 2 more to go. 1 more to go. 1 remaining. Ask a question. Only you can have a question. Okay, then we'll go with the 4 and answer them.
Okay, thank you for the kind feedback. I will answer them in the order that they were asked. The first one is on the publication of the case that I used for the cesarean scar. It's on Radiopedia. Now, the thing is with Radiopedia, most of our cases that we publish, they are normally under your profile. It's not like Eurorad where you get PDF format cases that you can share. So under my profile, if you search my name on Radiopedia, you should be able to see all the cases. There are about 18 of them or so. I don't know if they are, I may be exaggerating to look good, but there are a few of them, some of them in abdominal, some of them small parts. So under it, you should be able to see the cesarean scar endometriosis case. Now, regarding chaperones during ultrasound, I'm always an advocate of patient comfort, whatever it takes. So chaperone is the first step regarding patient comfort. So myself, when I'm performing any ultrasound, especially most of these ultrasounds that I'm trying to avoid the word intimate, but these private ultrasounds. So when I'm performing them, I'm an advocate of having chaperones, especially spouse ones. Some of us who have patient attendants, who have PAs, you can also use your PA or your radiology nurse, because some of these ultrasounds are very intense to begin with, especially if you are performing an ultrasound during such a case. So you will spend quite some time. Some of these patients that you see will be in critical conditions. In a case in point like ectopic pregnancies where you are performing transvaginal ultrasounds. So myself, I am an advocate for having chaperones. I'm also an advocate of acquiring consent that is informed and written. When it comes to the male sonographers, having worked in different communities, I have worked with a Muslim community, an Indian. Currently, I'm working in an Indian community. This is a challenge that we face on a daily, where patients do not feel comfortable having you do the ultrasound. Now, we are trained to ensure that the patient always feels the best about the procedure that they had. Therefore, different facilities will have different standard operating procedures. Luckily for me, I have female colleagues who are as qualified as myself to perform these examinations. So if in an emergency setting, we normally rebook the patient at another time if there is no available lady. But ultimately, if a patient requests a different practitioner, I feel like it's important to understand their point of view and actually try and make them comfortable. When it comes to citations, now this conversation about endometriosis is more of an international conversation right now. The people who are premiering the conversation in Kenya, as far as I'm concerned, is that Park Hospital. Not even most of our national hospitals themselves have not actually started doing what we are talking about right now. Of all the information that I've gathered in this country and all the workshops that I'm aware of have been done by that Park Hospital, Dr. Njagi, Dr. Yamal Patel. They are a very good team. They hold training workshops where they show people how to scan. I talked to Dr. Njagi about 6 months ago. They had a certain workshop, but as of now, they are not open to sonographers, which is why I was requesting the council if they can actually look into it and see as to how us as sonographers can get trained and improve our skills on things that are similar. In the future, we are hoping as more people go into academia that we'll have better presence even internationally, where we will be cited, and next time we are hoping if we have a similar event, we can be able to use someone's data set to present the facts that we are using in such presentations. But for now, this is what is available, the International Deep Endometriosis Analysis Group. So that is what we are using. Lastly, thank you all for the good feedback regarding the episiotomy site and all the surgical sites that endometriosis can implant into. This is a very dynamic disease. As we said, it can even be thoracic within the pleura. So it's an aggressive disease, and you have seen champions who have succumbed to it, who are still fighting it, and therefore I feel like we as sonographers need to take up our part when helping with the fight. So thank you all, and I hope you all have a good day.
Thank you so much, Mr. David. You're the kind of person who makes us to be proud radiographers when we walk outside here. You know that when you need someone to talk about ultrasound, we'll always think about you. And it's a lot of work to be put together for you to have the courage and the knowledge to have such presentation. Feel encouraged always. So our next presenter is, I don't know which title to use. Doctor? Mr. Yeah, but understand at times Mr. is superior than doctor. So I'll go with it as it's written. Mr. Martin Kamanda can introduce himself. I know he wears a lot of, a big, I can't even tell. Yeah, he's my teacher. He's been my sponsor. Sponsor in the field of radiography.
Thank you, Lisa. Let me start saying that I'm very proud of Negwa being your lecturer. I have to be proud. That was a good presentation. And I will also encourage the other students also to be present. Lucy, you should be presenting as well. Now, before I go to my topic, I wanted to mention something Negwa mentioned about the chaperone policy. So, from my experience where I work, we have a chaperone policy for intimate and sensitive examinations. And one of the areas we've covered is LGBTQI. You have patients, lesbians, a couple, they come, they don't want a female sonographer to do the scan. They want a male sonographer to do the TVS and a female to be a chaperone. So there are those dynamics that we need to understand. And as medical professions, we are blind to the race, sex, age, and all those other factors about patients. So we are getting those kind of challenges. Even our request form, now we are being told not to write the gender. We write male, female, and others. So those are things that are happening in the private sector at least. So I don't know about the public. Probably you'll catch up. So yeah. So let us put, what I would say, let us put religion aside. Let us put our personal beliefs aside. Let us treat the patient. Okay? Ours is to treat the patient. So having said that, two things I wanted to say before I start the presentation. That one was to Molly. It's the University of Nairobi, not university. So when I was developing this topic, I really wanted to talk about the technological advancements that we have. But then I realized that's not very important. What is important is what we have at the moment and what we are not using as medical professionals. Maybe for the ultrasound people, maybe I begin like this. How many of you know about cell-free DNA in ultrasound? Anyone else? Pre-implantation, genetic testing? Yes. So these are tests that are being done, genetic tests that are able to predict by 99.9% that our features will have some chromosomal abnormalities, Down syndrome and all that. Okay. So that's where the world is. We are having these tests that are very, very accurate. But are these tests a substitute to imaging? The answer is no. Okay. So that is the inspiration of the role of clinical markers, not as a surrogate in CT imaging. Surrogate just means substitute. I had written substitute, but because I sent the presentation to my PhD supervisor, he said, replace the word. so this is why professor will say that. So what we are saying is, we have these markers that people, anyone knows about this CRISPR? CRISPR, clustered, random, interspaced, palindromic repeats. Anyone? So this is a genetic tool for editing your genome. That if you have a patient who has cystic fibrosis, we can use a genetic tool to cut the offending DNA and cure the disease. So this is where the world is in. So the world right now, even when you talk to people in GE, we are going towards precise imaging or precise diagnostic imaging. We want to use the clinical markers and the diagnostic markers to make a precise diagnosis. So we are moving towards precise imaging. It's no longer about you listing so many differentials. It's about us having one diagnostic finding. All right, so what are these clinical markers? So these are just measurable characteristics that are used to determine the presence, absence, or track the progression of a disease. And these are things you know. These are not things that you don't know. These are things you know. What maybe you don't know is, can we optimize them for imaging, especially in CT? So we have genomic, proteomic when you're dealing with proteins. We have diagnostic markers. Everyone knows about them. Anyone who knows about diagnostic markers? We know them. BIRADS, TIRADS, VIRADS, CORADS. You know, those are our diagnostic markers. But most of the time, clinicians have learned to use the diagnostic markers for diagnosing our patients. So if you tell a patient, if you tell a doctor that the patient has a BIRADS 2, they'll understand what you mean. But as we as radiographers, if someone comes to you and tells you that this patient has a GCS score of 5, do you understand what is meaning? Yeah? Do we use the same to optimize our imaging protocol? So mine is just to show you how these clinical markers, we can use them for protocol optimization. And there's a feedback loop. We have clinical markers. We use them to make a decision on the CT protocol. Then we have our diagnostic report, and then we generate our diagnostic markers, which are thyroid, scorat, and all those other things that we make. So the first thing I'll start is blood pressure. Everyone knows what blood pressure is. Yeah. How do you apply it in imaging? Okay, in fact, I'll not go to that slide. The first thing is stroke imaging. Yeah? You have a patient, you're being told high BP, CT scan head. So the first thing you notice is the doctor is requesting to see a CT whether the patient has stroke. And there are two types of stroke. We have infarctive and hemorrhagic. We all know that. But sometimes, are we able to go further than what we know? For example, a patient comes in with, for example, this is a patient who had an acute infarct. So, would you stop it at that? Yeah. So if you have a patient with an acute infarct, for example, what do you need to do? Because this is a critical finding. You need to inform the radiologist within 30 minutes. And if you're in a setting where there's an MRI, we need to do an MRI. Or you do just T1, T2, DWI, and ADC. We save the patient's life. Most of the time, we normally say, there's cost implication. But I can tell you, if you send this patient to an MRI and you save that life, because brain is time. Okay? So what I'm trying to say is, let us save the life of the patient. Let us not wait. We send the patient to casualty, they send back to MRI. Okay? So that's very, very important. Again, you have a patient, the first patient is what? Has subarachnoid hemorrhage. And you noted it down, and then you release the patient. That's wrong, isn't it? You can call the radiologist and convert the same to cerebral angiogram. And you can do a cerebral angiogram using the least amount of contrast. For those who have taught, we said we inject at a faster rate so that the peak enhancement is very high. And we're able to get very good angiogram. And you can see in this patient, let me put a laser. This is a patient who had an aneurysm in the anterior cerebral artery and another one in the M2 segment of the middle cerebral artery. And you've done your CT scan at the same setting. You've not transferred the patient to A&D, only to call the doctor to say that bring the patient back. So most important is, let us put our patient. It could be your relative, it could be your brother, it could be a colleague. So if I scan you, God forbid, and I get subarachnoid, I'll not send it to A&D. I'll go beyond. Let us deal with the cost implications later, but let us save a life. Now, what are the other causes of high BP? So this, I think, is what most people don't apply. So BP could be caused by hypersecretion of aldosterone. Aldosterone is just a hormone secreted by the adrenal glands. It has two functions. One, it will cause vasoconstriction of the peripheral arteries. And two, it will cause preferential absorption of sodium and preferential excretion of potassium. So you find that a patient comes, young patient, high blood pressures, they are not being controlled. They have low potassium levels, high sodium levels in serum blood. Okay. And there are two types. One, we have primary, where aldosterone is high, renin is low. And then we have the secondary one, where because of activation of the renin, angiotensin, aldosterone system, you have renin is high, aldosterone is high. So if you have these markers, what do we need to do? First thing is to check, is it primary or is it secondary hyperaldosteronism? Because the protocols are different for the two. So the first one, you want to determine whether the patient has a lesion in the adrenal gland, which in this case we have primary hyperaldosteronism. Renin is low, aldosterone is high. And normally we want to see the washout of the adrenal gland. So we'll do non-contrast, photovenous, and a delayed phase. And when I talk about a delayed phase, I don't mean an excretory phase. There's a difference between delayed and excretory. So we normally do a triphasic scan, and we measure the Hounsfield levels of the adrenal gland, and we calculate the contrast quotient. Because we want to differentiate, is it a lipid-rich, lipid-poor adrenal mass, is it a benign mass, is it a malignant mass, and all that. So what I'm trying to say is we are moving towards being scientific in a way, in our imaging. And you'll never miss these issues once you're able to look at the clinical markers and apply them to protocol optimization. So the other one is renal artery stenosis. Renal artery stenosis, the moment you have renal artery stenosis, we have that cascade of renin, angiotensin, aldosterone system. And renal artery stenosis can be caused by retroperitoneal fibrosis, which is just a scar tissue forming around the renal artery. Although primarily it affects the ureters. Then you have Takayasu arteritis. Anyone who has diagnosed Takayasu? I'm sure you have. Maybe you didn't recognize what it is. It's just an inflammatory disease affecting the branches of the aorta. Okay. So they narrow down, so you have patients with different pulses. And then you have fibromuscular dysplasia. Again, it's an inflammatory disease that narrows down the renal artery diameter. So the protocol basically is a renal angiogram. So we don't want you to do an abdomen, and yet the doctor has told you that this is a young patient, high blood pressure, the renin is high, aldosterone is high, and you just do an abdomen. This is a patient who's young. You just need to do non-contrast and early arterial phase, and you are done in the scan. Because sometimes you find that these patients, we are doing late arterial phase, photovenous phase, delayed phase, excretory phase, and we send them for reporting. Because we are blind to the clinical markers that we can use. So always read the file. Even if the history has been provided, you can always probe further and get the right protocol. The other thing is pulse rate. We normally use it for cardiac imaging most of the time. And we know that if your blood pressure, your pulse rate is above 70, you will not get a good coronary angiogram because the heart is in a state of flux. And we sample our images at the diastolic phase. So in cardiac imaging, that one we know. There's another condition that maybe most people don't know, is coarctation of the aorta. So these are patients who come because you have narrowing of the aorta just distal to the left subclavian artery. You find that this patient, when the doctor checks for pulses, the upper limb and the lower limb, there's a difference. Okay? They'll tell you that the upper limb pulses and the lower limb pulses are not equal. Okay? So that's something that in your back of your mind, you know that this patient needs an aortogram, isn't it? To check for coarctation of the aorta. So that's how we apply some of these clinical markers in imaging. Because I have noted, even where I work, that we rarely use the clinical markers that are provided to optimize our protocol. And we end up missing a lot. So the other one is creatinine. Everyone knows about creatinine. Okay? And they normally use it to check whether the patient has acute kidney injury, chronic kidney injury, or end-stage renal disease. Now, protocol advice most of the time is non-contrast. However, there are instances where your kidney function is deranged, but you have to do the scan. For example, a patient is sent for CTPA. It's a matter of life or death. Sometimes we'll have the patient signing the consent, doing the hydration, and we do the pulmonary angiogram. However, always ensure that the patient and the doctor sign the consent. And they only sign the consent after you've explained the risks versus the benefits. Okay? So it's very, very important. So that if they get renal injury as a result of the scan, As a radiographer, you're also protected. So what we've done in Nairobi Hospital, we have a concept for patients with high creatinine levels. Okay. Where the doctor signs, the patient signs, and the radiographer signs. So it's very, very important that you have this consent forms. Now, the other function of creatinine, this one again, most people don't know. I'm just assuming, maybe you know. So we normally have patients who come in with ascites, okay, maybe after surgery, and they do an ascitic tap. They analyze the ascitic fluid, and they find that the ascitic fluid has high creatinine levels, but the serum creatinine levels are normal. So what will that mean? That there is leakage of urine into the peritoneal space. And what is the best protocol? Excretory phase. This patient does not need late arterial phase, portovenous phase, delayed phase. We just need to show the doctor that this patient has extravasation of urine. And I'll give you a good example. So this is a patient we scanned in my previous workstation at Episha. And you can see the patient had a stent there. So this was the pre-contrast scan. So I've already read the file. Patient had ascitic fluid tapped, creatinine levels are high, and you can see there's a bit of fluid build-up around the kidney, on the other side. There's a bit of air locules within the stent. And what we did, we just injected the patient with 40 cc's of contrast, did the topogram, waited for 8 minutes, then we did a delay. And you can see there's active extravasation of a contrast. So I've given a lower initial dose to the patient, and I've given a precise diagnosis. Okay? So let us move towards precise imaging. And precise imaging always gives us precise diagnosis. Now D-dimer, again D-dimer, everyone knows about D-dimers. D-dimers usually, when they are high, we normally associate it with clotting. D-dimer is just a breakdown of fibrin. Okay? So when you have a clot, usually when you have a clot, it's just an aggregation of platelets, and fibrin forms around it. And when the breakdown of the fibrin starts, it's usually done by something called a plasmid. It breaks down the fibrin into small particles, so then you have elevated D-dimer levels. So D-dimer is another common marker. We also have troponin, okay, which is used to diagnose heart damage. So sometimes we advise our radiographers, if the patient has high D-dimers, high troponin, you can do what we call a triple rule-out CTPA, where you want to show the opacification of the pulmonary arteries, the coronary arteries, and the aorta, both ascending and descending, at one injection rate at one. It's a bit difficult, but with practice, you'll be able to see. So you'll be able to diagnose this patient. You'll show your pulmonary artery, you show the ascending aorta, descending aorta, and your coronary arteries. So you've ruled out coronary artery stenosis, you've ruled out PE, you've ruled out dissection of the aorta. And you've given that information in one image. You can just say the patient does not have all those entities. Because sometimes you find that this patient, again, they are sent for imaging later on. Wells score. Wells score is also used in conjunction with the D-dimers. Wells score is a risk stratification for CTPA. So anytime you have a patient with a Wells score of more than 6 points, there's a high probability that this patient will have PE. And therefore, what it does, when you do the scan, because it's a critical value, and you find that the Wells score is high, yeah, relook at your scans again. Okay? Because you can see we've looked at the clinical signs and symptoms of DVT. Maybe the patient has swollen legs, short of breath, then all this immobilization, surgery, prior DVT, PE, hemoptysis, and all that. And we've stratified this patient. So sometimes it's very, very important you look at the images and see whether this patient has a PE. So, and actually, one of my students did this study locally in Kenyatta. It's called Richard Okari. And we found that 57% of patients who had a positive well score, they had PE. So well score is very, very important when we want to diagnose PE. Glasgow Coma Scale, I'm sure this one, most people know about GCS. Some don't, some know. So anytime you hear a patient has a very low GCS got 15 out of 15. So we look at the eye-opening, verbal response, motor response. So if casualty calls and they tell you the patient has a GCS score of 3, you need to prioritize that patient. Okay, there are not two ways about it. Because we had a case, casualty called, they informed the radiographer, patient had a GCS score of 3. The radiographer didn't understand what GCS score means, so he continued scanning other patients. Okay, so these things might look straightforward, but many of us know about it. So GCS score, prioritize the patient, report the critical values of findings. They're supposed to be reported within 30 minutes. So if a patient has hemorrhage, fractures, and all those things, it's good to inform the radiologist. If there is no radiologist, depending on where you work, you can always call the physician. Again, it depends on how confident you are in image, pattern analysis and all that. But for those who have taught, I'm sure they know how to report these things. Yeah. Pancreatic enzymes, everyone knows about these. High amylase and lipase level usually associated with acute pancreatitis, and we'll do a biphasic CT scan protocol. So this is a patient with acute pancreatitis, and you can see on the third day there's a bit of necrotizing pancreatitis. Islet cell tumors, these are very rare tumors, and they're not so rare. It's because sometimes we don't understand the clinical profile of the patient or the clinical markers associated with these hormones. So we have insulin, gastrin, and a somatostatin. And the tumors are named same: insulinoma, gastrinoma, somatostatinoma. So the first two, insulinoma, young patient who is hypoglycemic because they have hypersecretion of insulin. So they are hypoglycemic. They are put on treatment, they are not responding to treatment. Okay? So what protocol do we use for that? We have gastrinomas. These are patients who have high levels of gastrin. And they normally get very, very bad peptic ulceration. And the word for it is called Zollinger-Ellison syndrome. Okay? So you get that clinical profile. How do you proceed from there? So first thing you notice that this patient has an islet cell tumor. And the protocol advice is early arterial phase. These tumors are small and they show peak enhancement on early arterial phase. You're likely to miss them if you do portovenous phase alone. And I'll show you a good example. So this is a patient with an early phase. You can see we have our insulinoma there. When you go to the portovenous phase, the lesion has disappeared. So islet cell tumors always do an early arterial phase. They might be rare, but you'll meet them for those who are doing CT imaging. Okay. So look at the clinical profile of the patient and customize your protocol properly. So we have tumor markers. We have alpha fetoprotein, which is normally associated with hepatocellular carcinomas. Protocol advice again, late arterial phase, portovenous phase. We just want to show washout of these tumors because HCC will behave differently from a cholangiocarcinoma, for example. So HCC, hypovascular on late arterial phase or early arterial phase, then it washes out. It becomes isolated to the liver parenchyma. Things like cholangiocarcinomas, they'll show delayed enhancement because they have a fibrous component in them. So this is a peripheral cholangiocarcinoma. And just let me mention, because I normally said this in the exam, cholangiocarcinoma is not a GP carcinoma. Okay, it's a big difference. the tumor arises from the cholangiocytes, from the bile ducts. So sometimes I find students confusing GB carcinoma to cholangiocarcinoma. So this one is arising mainly from the bile duct and not the gallbladder. So we have carcinoembryonic antigen. If it's elevated, we are looking at colorectal carcinoma, pancreatic carcinoma, lung carcinoma, or stomach cancer. So protocol advice, I'll just go through very fast. For stomach, let us distend our stomach properly with water, not contrast. Water gives a very good contrast agent, negative contrast agent. So we'll have two types of tumors. One is exophytic, it's growing outside the lumen. And then there are those which are endophytic. So these are GIST, these are gastric carcinoma. Okay. There's another condition that makes the distensibility of the stomach become poor. I don't know that anyone knows about it. Deco? Sometimes you want to give this patient water to fill up the stomach. They're not filling up the stomach. What do you think, Caleb? You've seen it. Yes, you've seen it. I know. Rhinitis plastica, isn't it? Rhinitis plastica. So if a patient has rhinitis plastica, it's a tumor that affects the stomach. So this means they will never be able to achieve gastric distensibility. Okay? As much as you give them contrast. Other patients who have done gastrojejunostomy, you never achieve good gastric distensibility. Okay? So again, patient by patient. Pancreatic adenocarcinoma. Again, we want to see the relationship of the tumor to the artery and to the veins. Okay? Because if the tumor encases, can't see this is standing, I'm finishing. If you see the tumor encasing 180 degree of the vessel, then the tumor is not resectable. So always when we are scanning patients with pancreatic adenocarcinoma, let us ensure that we show the relationship of the tumor to the artery and to the veins. Good. Okay. So I think I have spoken about pancreas, ovarian cancer. What I didn't mention is lung carcinoma. Lung. We want to include our upper abdomen. And the reason why when we are doing lung, patient with lung carcinoma, we want to include our upper abdomen. Reason? Meds. Meds are going where? Not really. Common side of the meds for lung carcinoma, please. Adrenal. Yeah, adrenal. It's theorized to be hematogenous spread. Remember the inferior phrenic nerve, inferior phrenic artery gives off the superior adrenal artery. The middle adrenal artery will rise from the aorta. The inferior adrenal artery is arising from the renal artery. So that's the anatomy. So we have a branch of the inferior phrenic artery giving the superior adrenal artery. So we have metastatic deposits in the adrenal. So when you're doing lung carcinoma, include the upper abdomen, at least up to the tip of the kidneys and all that. Okay, so lung carcinoma again, usually I see people not just going below the diaphragm, which is all right. So you have ovarian carcinoma, watch out for peritoneal mets. Other tests that I'm not going to mention so much is PSA. I know most people know about PSA. Pregnancy test, again, a bit controversial. If a patient comes, is pregnant, they're sent for CTPA. Do we do the CTPA or not? We do, isn't it? But they sign consent. How do we protect? Again, another debate. For safety, how do we put the left down on top or do we wrap around? It's a big debate there. You wrap around because the tube protects. Unless you have a dual energy. A dual energy scanner will do the 180 rotation. But if you have a single tube, then yeah. So there's a debate about that. But for me, wrap around. Okay, and then you do the CTP. And don't do the lower limb. Leave that one for ultrasound. PSR for COVID, I think everyone knew about PSR. When PSR was raised, we knew that you have COVID and we'll take your So thank you so much. And last but not least is that as we go on, these tests are becoming more and more sensitive. There's a time we reach where we have a test that can tell you that this patient has a probability of developing contrast-induced nephropathy or kidney injury as a result of contrast agents. So we hope that one day we'll be able to do such a test that tells us when you pair contrast, the probability of him having kidney injuries is very low. So things are developing as we go to genetic testing and all that. So thank you so much. Thank you.
We are now taking questions. We'll take all the questions together.
My question is on the colorectal tumors, because during the test most of the time you find that sometimes it's difficult to evaluate them when you give it the positive contrast. But if you check the preparation of the patient, like in our center, we prepare the patient with dose for 3 days before the examination. But we find that still, this patient has not experienced most of the fecal matter. So the evaluation becomes a bit difficult. But now, we've tried it with using mannitol as the positive contrast. And we find that for this evaluation of colorectal tumors, most of them, using the mannitol becomes best because we find the patient and we like them to get a low stool as they continue taking the oral contrast. So we find that it's a little bit better to evaluate the tumors using the mannitol like the other normal positive contrast. Yes.
Yes, mine is to ask you, we have had cases where patients who are due for dialysis and they have very delayed UCs. And the clinician says you just go ahead and that we are going for the dialysis for that. That's all they have to just go through the other issues and then proceed.
Mine is not really a question. I've just remembered the challenge that we face when we image our patients, and I'm comparing this what's happening in private and now in a public facility. One of the biggest challenges that we face is that these critical indicators, at times the doctors do not include enough clinical information on the request forms that are sent to us. There are times really a challenge. It was easy when in private you can reach out to the doctors, you can call the doctors, the contacts are available. At times it's really a challenge in government facilities because you can't find the doctors. Thank you. You tell us probably how you go about that in the institution.
Any more questions? I think no recommendation, no comments.
The recommendation is there. It's from the presentation is so deep, and I realized there's a lot of professional ignorance and The practice level that we are experiencing, even the senior medical practice level, then towards us, there is a lot of ignorance. I think when we focus on this, we need to strategize on how we can shift the medical setup of Kenya to high standard, because we are practicing a lot of something that's not radiology, by the way. There are just request forms coming, the radiology, we are doing abdomen without seeing the clinical history, a lot of things. But if we do such conferences openly and involve, I think you need to organize for a big space. We involve almost all people practicing this in this field. We will save the society of Kenya. If not so, we are the first and madras.
So we stop doing that. Medical space.
I'll start with the CK's question. It's very, very important. And this is a challenge to the people who are doing clinical work. Some of us are in management right now. So the challenge I present to the clinical people, share your cases. Even me, some of these things, like the urinoma, the first urinoma I missed, because I didn't understand what it means that to have an ascitic fluid with high creatinine level. But I would go back and read, and now I'm sharing it with you. So let us share knowledge. Let us come to this forum. Let Sydney have so many presentations, because sometimes Sydney is struggling to get presenters. I can tell you that. It's struggling to get presenters. So have those good cases with learning points, come and share with us. Oguna, we are still waiting for your presentation. For PET, we need to see what you acquired. Okay, Caleb, CT, Deg was shared. So some of these things is sharing. With us, we cannot share forever. You'll get bored by me. So one time I want, even me, I sit there and listen. You share with me something that I don't know. So that's a very good challenge that I must admit. Now, I'll start with Caleb. What I said when I was doing the topic is, these clinical markers are not a surrogates to CT image. They are not a substitute. So sometimes, if you feel that the clinical markers are a bit off, you can choose the best protocol for that patient. So it's all about application. Just optimize the protocol. Someone talked about colorectal tumors. Yes, I saw you're using mannitol in Mombasa Premium. It usually works very well. The thing is about the costs. Okay. But mannitol is very good for distending the colon, unlike positive oral contrast, which we normally give our patients to take. Deranged UECs. Now, there are two issues here. If a patient has acute kidney injury is reversible. Okay, that's number one. Chronic kidney injury is not reversible. So someone with AKI, unless it's very well justified, I'll not want to give that patient contrast. Unless the critical event, unless it's something like PE, something like aneurysm and all this. Because we can reverse it. I will not want to damage the kidney further. For a patient with chronic kidney disease, which is not reversible, then I can give them the contrast and we do the dialysis. Patients with end-stage renal disease, you're not damaging the kidney further. It's damaged. So you can always give contrast. Okay? Yeah. And some of these patients actually, especially patients with the AKI, or when you give them contrast, how is it excreted? Anyone? If a patient has a kidney injury and you've given contrast but bad, how is it removed from the system? The kidneys are damaged. Huh? Sorry? No. So patient with given contrast, kidneys are not working. How will it be excreted? Through the biliary system. Yeah. It will come, it will be stored in the GP, come to the common bile duct, to the duodenum, excreted in stool. Actually, when you scan those patients, 24 hours later, you find the GP is concentrated with contrast. Yes. So just know, is it AKI, is it CKD, or is it end-stage renal disease? And you make a decision. And sign the consent. Yeah. Ndio. Consent. Okay, for private sector, consent is usual. Kawaida. So public, I don't know, but private, you cannot get away with it. For Guna, last question for Guna was if the clinical history is not provided, it's good to make an attempt. Okay. If a young patient is sent for a CT abdomen and they don't have right iliac fossa pain, they don't have features of small bilaps, I'll be curious just to know why they've been sent. Yeah. So sometimes what I normally say is imaging is governed by three things: anatomy, pathology, and technique. And pathology will always dictate the technique, not the other way around. Technique will never dictate pathology. It's pathology dictating the technique that you use. Thank you.
Thank you, Mr. Martin, for your presentation. Our next presenter will be introduced by Sydney. But before we go there, I want everyone to open below their table. There's some goodies over there. The person who finds it will be announced the winner. Just open below your table. Below your table. You're not opening the table? Yes. Below, under. There's something under the table. There's something under the table. One of the tables. Maybe it's the one not being opened. Thank you. Any winner? Anyone who has gotten it? No one. So everyone is awake. We'll check the next round. Sydney, you can have the microphone. Otherwise, thank you for being attentive during the session. We are almost done with our second session of the day. As Sydney is trying to do connections, I think our next presentation is going to be online. So keep your eyes glued on the screens. I know you have the capacity of joining online on your phone. Kindly don't join on your phone because you don't want to interrupt the session. Our next presenter is Dr. Oraj Dickman. He will introduce himself further. In radiography, we have a lot of talents. I know we have musicians, dancers, and one time we even need to hold a competition for eating. I know we have all those talents. Okay, Mr. Sid.
Dr. Raj, just give us some few minutes. Yes, we can hear you, but you can be writing your presentations. Your co-host, you can try to load your presentation. Excellent. We can see a presentation, but we need to test whether we can be able to hear you from our side. Maybe you can speak. on for some few minutes. So we hold on for a few minutes. We need to know the speakers which are here. The speakers are here. They are waiting for the tail guide. So, Dr. Lange, just hold on. We are working on the sound so that we can be able to hear you from the room.
Okay, no worries. Just let me know when you need.
Okay. So, Excellence, as we wait for us to be sorted out the sound in a few minutes, as you are aware that even Martin has not mentioned about wires because we didn't go to college. We leave it to the experts to work on that. But are we happy with the presentations? Wonderful. So I think you too, you can present. So I know we are loaded, and that's why I say that none is better than the other one. We are here to listen, maybe the hours of the days are limited. So if we had more hours than what we have, we would have loved to listen to majority of you. The good thing that I'm happy to interact with most of you at the working areas. And we are doing excellent work. And I think what we are being presented here is now what you see this discussion we keep on asking if like what Esther was presenting in the morning, if ultrasound focus point of view accounting, is it replacing our position? But if you go deeper in this way, are you going to be replaced? But if you do just like the way they are doing, now there is a danger there. Because there is a danger there. But as a radiographers now we take it to the next level, and we, instead of just doing that measurement, circle, calibration and the rest, pushing the button, now we go more deeper and we are able to challenge what the clinicians are doing. So we can ask. So you can try, Dr. Lange.
Okay, so this is me trying. Can you hear me?
So where is your speaker? Because we can trace it here.
So let me know when you can hear me.
Yeah, I mean.
Okay, you can hear me, but can the audience hear me as well? It is not yet. So, well, shall I keep speaking or
A minute, we are almost there.
Okay, okay. I know how challenging it can be to set up these calls, these connections.
Excuse. So, because we are Zoom, I need to know from the audio which speakers you are connected to. I click among these ones, negative.
They're supposed to be viewed from here. See? It's supposed to be viewed. This. It's at the end of the house, actually. See?
Yeah, yeah. Big. Let's see.
Okay. So you are here. How is it? It's it.
Then that is HD to input speaker and I added this with something. HD to speaker.
That's the one.
So still get it apart from there. Dr. Raj, now you can trust. You can test.
So, can you hear me?
Yes, we are good. Go ahead.
Okay, so now that I'm given the green light, let's start this out. So I would like to greet everyone. I'm just going to Cindy, I'm going to decrease the volume on my side because I have a certain feedback.
Okay, we can switch off the Zoom
Okay, no,
in the
I
room.
think it's good now. Can you hear me
You
clearly?
get. So if you have Zoom, switch it off or maybe put the earphones.
Okay, so greetings everyone. I hope that you are having a great meeting today. I would have loved to be there with you because most of you know how much I love being in Kenya with you, our colleagues from SORG and other institutions. Today I will be talking about VisiPAG and its use in at-risk patients. As you know, the contrast media that we are using, as has been just mentioned right now, has to come out somewhere after it's done its job in the body. And for a negative contrast media, it's the kidneys. And the properties of this contrast media sometimes can do damage and harm to the kidneys. And one of the key factors in this is osmolality. That's why osmolality of the contrast media is important. As you know, osmolality is the attribute of soluble materials flow out water from one compartment of the body to the other. And in biological systems such as the human body and other living beings, the flow of free water continues until two sides of a semi-permeable biological membrane are osmotically balanced. In other terms, if there is more soluble matter on one side than the other, then you'll have a flow of free water from one side to the other until the balance of soluble matter has been achieved. That is one of the key factors in the damage that is caused by contrast media after its administration. Due to this impact of osmolality, the development of contrast media since the 50s has been towards obtaining lower osmolality contrast media through the elimination of ionic side chains and coming up with chemical structures that allow for lower osmolality. This can be in the form of monomeric non-ionic contrast media or dimeric non-ionic contrast media. So whatever happens, keep in mind that even although we name the current widespread used contrast media low osmolar contrast media, they still are 2 to 3 times higher than blood's osmolality. The only thing low about low osmolality contrast media is their relatively low osmolality compared to the high osmolars that were pretty much abandoned in the 1980s. So the earlier generation of contrast media, the high osmolars, were 5 to 8 times higher than blood osmolality. So when we had the newer generation come into play, they were called low osmolality because they were in fact lower than the high osmolars. But as I said, they still are 2 to 3 times higher than blood osmolality. At this time, since the 1990s, the only isoosmolar contrast media that is available on a global scale is iodixanol, that you know under the brand name Visipac. But before I come to Visipac, or the advantages of using Visipac, the isoosmolar contrast media, in high-risk patients or at-risk patients, let me take you through a very swift journey. So let's see what happens when you inject a contrast media into the patient's body. So once you inject your contrast media or any other type of hyperosmolar medication, there are certain elements that are triggered, and all of these, or most of these elements or pathways, are working towards the balance of electrolytes or balance of osmolality in the circulation. So to be able to balance out the osmolality of these injected contrast media materials, you need to have a certain flow of free water from one compartment or the other. So the first compartment that the physiological systems tap into is the extravascular space. For free water to flow into the intravascular space, you need to have an opening in between the endothelial lining of the vascular system. So this will mean that more free volume will flow into the intravascular space, and you will have an increase of circulating volume. The second source that is tapped into is the water that is contained in the erythrocytes. So when the erythrocytes lose their internal water, they become echinocytes. They lose their morphology and plasticity. The third problem that occurs during these mechanisms is that the endothelial lining controls the vascular tonus. So during these phases of water displacement, the vascular tonus was also impacted. So in the next slide, I will demonstrate which mechanisms are impacted once again. So when you inject anything that is hyperosmolar, this triggers an increase in sodium and water expression and the stimulation of the tubuloglomerular feedback mechanism, leading to decrease in glomerular filtration, which impacts the kidney functions and causes a decrease in kidney functions. The second mechanism is the impact on endothelin and adenosine. As I said, the endothelial lining regulates the vascular tonus. And when this system is impacted, when the endothelin and adenosine levels increase, this creates vasoconstriction. And vasoconstriction decreases renal blood flow and once again disrupts renal function. And the endothelial cell injury, the impact on the endothelial cells, creates narrowing of the vascular lumen and impaired vasodilator activity, once again impacting the renal blood flow. This is important for tissues that rely on capillary oxygenation, because you have to understand that the capillaries at the level of the kidneys and the heart are so narrow that they only allow a single line of erythrocytes to pass through them and carry the oxygen. And when this lot of impact on the kidney and the heart. So I will come to that in the later stages. The second problem is that for the erythrocytes to fit through this capillary perfusion, they have to be able to be flexible enough to squeeze through these capillaries. So they need to maintain their morphology and plasticity. But please remember the previous slide, because of the loss of internal water, the erythrocytes are already losing their plasticity and morphology, so they can no longer squeeze through these capillaries. So that adds on to the insult on the kidneys and the cardiac perfusion. The other problem is, as I said, the altered morphology of the erythrocytes. This creates not only rigidification, but also a tendency to create aggregation, blood clots. And this impedes capillary perfusion, leading to renal function loss. You might be asking yourself, how bad can the situation be? How bad would the erythrocytes be impacted? So here's the answer. You might lose up to 80% of the morphology of your erythrocytes. And the more you lose the morphology, the bigger the impact on the capillary perfusion. When you use VisiPack, so this is an in vitro study, you are able to preserve the majority of your erythrocyte morphology and structure. But as you can see here, if you incubate erythrocytes with different contrast media products other than VisiPack, you are likely to lose up to 88, nearly 90% of the erythrocyte morphology. So not only they can no longer squeeze through the capillaries, but the capillaries themselves are also impacted. So the vascular lumen is narrowed, the endothelial lining cells are buckled, and these all impede or disrupt the capillary blood flow. One other problem is the impact on the electrophysiological systems. So the electrolyte content in the contrast media can also disrupt certain physiological functions, such as the pacemaker system, the cardiac muscle, and electrophysiological systems that control our central nervous system. So all these factors are culprits of varying complications following the contrast injection. That's why the tendency is to lower chemotoxicity, lower osmolality, and balance the electrolytes that are contained in contrast media. And let me talk about the impact of contrast media on the kidneys and the heart. So these fluid shifts create dehydration of red blood cells and increase cardiac workload due to the mechanisms that I already mentioned. And also the increasing circulating volume creates a volume overload, once again decreasing cardiac function. And all these impacts on the physiology create an impact. So they increase complications such as bleeding, myocardial infarction, and morbidity after the injection of contrast media. And especially after intraarterial procedures such as interventional cardiology, it has been demonstrated that a shift from low osmolar products to VisiPack iodixanol has decreased the impact on the kidneys by at least 54%. So this is based on the McCullough study or meta-analysis from the US. And another meta-analysis from Dong in Korea have also demonstrated that, especially after interventional cardiology procedures, the usage or selection of VisiPack over other iodinated contrast media can decrease the complications such as contrast-induced acute kidney injury by 32%. So this is just to give you an idea that simply selection of the properties of a contrast media can have an impact on the patient's well-being. So the complications are reduced, patient comfort, patient well-being is ameliorated, and you have better outcomes for your procedures. This is another study, this is a meta-analysis from Zhang, that shows that if you compare VisiPack with another product such as iopramide, your outcomes are better with VisiPack after intra-arterial procedures. But these are relatively well-controlled studies. So meta-analyses are well-controlled, are based on well-controlled prospective trials. What happens in real life? We cannot select who we are going to inject our contrast media. That's why we look at real-world evidence. And the biggest real-world evidence that we have regarding the usage of VisiPack comes from the US. So this graphic shows the complications following intra-arterial PCI procedures in the premier hospital network in the US. This includes more than 300,000 patients that have received either VisiPack or other low osmolar contrast media products. And it has been demonstrated in this particular study, including more than 300,000 patients, that simply by using VisiPack and without changing any other parameters, you are able to decrease the relative risks for renal events requiring dialysis, acute myocardial infarction, angina, stent occlusion, stent thrombosis, and the composite of all these outcomes in a relative and absolute manner. So you are able to decrease the relative risk by 9.3% and the absolute risk by 0.69%. And you might be thinking that these figures are really small, but when you multiply these by the millions or hundreds of thousands of patients who undergo these procedures, this creates a big impact. And when you look at different comorbidities that patients might have, the worse the patient status, the better the outcomes. So the patients who are at higher risk of developing contrast-related complications, or patients who already have kidneys that are in bad shape, they benefit even more from this switch from low osmolars to VisiPack. And not only that, but not only the outcomes are better, but also the costs are improved because you are saving on complications. You are not needing to treat these patients. You need less hospitalization, less ICU stay, and you are wasting less resources such as your healthcare providers' time and supplies. So I'm going to show you how the patients and the economy improves with the use of VisiPack, especially in these intra-arterial or interventional procedures. So this is a theoretical model published by Angel DeFrancesco a few years ago in 2016. Angel DeFrancesco created a theoretical model that assumed there would be a complete shift from low osmolars to VisiPack in these European countries, and demonstrated that for Italy, Germany, Spain, and Poland models, you would look at somewhere between 25% to 34% in improved economies, so less costs for the payers. But the Premier database study that I showed you earlier provides much better insights. It shows that for every $1 that you invest in VisiPack, you are able to save $3 in return. So that means that you are saving $60 US dollars per procedure, $6,316 per hospital on annual basis, $130 million for a country the size of US on an annual basis. And this is because treating complications costs a lot of money, as you can see on the slide, and it creates longer hospital stays. And if you are able to prevent a complication such as major adverse renal and cardiac events, you will need to hospitalize the patients at least 4 days less than a patient who develops that complication. And that is what creates the cost reduction. So not only it improves patient outcomes, complications are reduced, and it costs less money to treat these patients. But not only this, but it has been demonstrated that patient comfort is preserved with the use of VisiPack based on another McCullough meta-analysis, and a further study, Rosenberg study from 2017, comparing iopamidol with VisiPack, shows that moderate and severe discomfort is much less with VisiPack, such as pain, heat, and general discomfort. They are much less VisiPack compared to iopamidol. So you are preserving patients' comfort, patients' well-being, and saving money from complications and hospitalizations at the same time. So it makes sense to switch to a isoosmolar contrast media whenever you are considering a patient that might run into complications or is at higher risk for contrast media related complications. This is once again another study from Wayland, and this showed that patients such as complicated patients requiring CTs due to malignancies, they suffer less discomfort compared to iopamidol when undergoing contrast-enhanced CTs. So, as I mentioned, worst case scenario, so as the functioning of the kidneys decrease, you have a higher tendency of developing contrast-induced acute kidney injury. This especially happens with patients who are treated for cancer. And patients who are treated for cancer are under many risks such as dehydration, hypercalcemia, hyperuricemia, and so on. But despite these complications, a study from the Mayo Institution carried out by McDonald demonstrated that for patients who have relatively good functioning kidneys, there is no big difference between non-contrast, VisiPack, and low osmolar scans. But as the kidney functions decrease, as the serum creatinine increases and eGFR drops, you see that low osmolars create more and more complications, but VisiPack performs as good as non-contrast control group patients. So the complications for VisiPack patients are at the same rate as patients who have been scanned without any contrast media. So that provides more insights regarding the safety and efficiency of VisiPack, because you are able to inject a contrast media and obtain the right kind of diagnostic data while preserving the patient from complications due to contrast. As I mentioned, the higher the comorbidities, the worse the outcomes for especially frail patients and cancer patients, because these patients are already exposed to nephrotoxic agents and complicated by other issues, are quite possibly dehydrated and are facing these complications due to advanced age. And all of these patients who might be at risk one way or the other due to certain comorbidities or risk factors, they all benefit from a shift from low osmolars to isoosmolar VisiPack administration. So, to conclude, I will say that to be able to reduce the patient's complications, preventive measures include identifying high-risk patients. That's the first step. The next step is ensuring adequate hydration, especially through IV hydration, avoiding additional strain on kidneys until the contrast media has been cleared out. So that's through delaying contrast procedures until the product has been removed from the system, minimizing the dose of contrast media to be used, and going for a lower or isoosmolar contrast media to begin with. So I would like to thank you all for your time and attention. If you have any questions regarding my presentation or VisiPack in particular, I will do my best to respond and answer your questions. Thank you very much.
Thank you, Dr. Rancho. Anyone with a question?
I think mine is a question to Raj, Sydney, and Ken. So two issues. GE has a good invention. It's a syringeless CT pump, where we don't need to buy the syringes.
Unfortunately, I cannot hear anyone. I think the room is muted. The account named Greg is muted.
Okay. So my question was, so the question was that GE has a syringeless CT pump.
I'm sorry, there's a very bad feedback, so I'm having a hard time understanding.
Okay.
Maybe if you could put the questions in the chat box, it might be easier for me to understand and respond.
I think I'll type it, but let me ask Ken and see, because this is a new. So we have the syringeless CT injector. Are we going to have it?
Apologies, I cannot hear anything.
I'm still waiting for it. So it will say that.
So you can't hear.
So contrast is like I know it's like that project where the sample they used contrast. Can we have the same mechanic where instead of throwing the contrast that you used, you can recycle it and maybe negotiate to save the contrast. Those are the two things that I think this part of the world really left us out.
I think you can type your questions online so that you can answer too. Anyone with a question? Anyone who has typed?
Whoever with a question can be able to use this mic direct.
Oh, direct. Assuming no one has a question, so you can read it with So that's the only question.
Dr. Alaj, you can check there is one question online or from your side. Are you able to see the question?
Oh yeah, I see that there is a, okay. What ratio of contrast to saline should one use when giving either or IV contrast media? So I'm assuming that this is related to the saline flush, so that would depend on the protocol that you are using. So there are different protocols that are detailed in the protocol guidelines and protocol booklets that we have produced over the years, so you can possibly refer to those. There is another question on contrast recycling. This is a very important important topic that we are taking very seriously. And in many European countries, we have an established program to collect unused parts of ionated contrast media and gadolinium contrast media, have these returned to the manufacturing plants and recycled for the reuse of ionated contrast media. And in certain countries, there are also programs or trials initiated to collect the ionated contrast and gadolinium contrast that are excreted in the urine. So these devices are placed in toilets at the healthcare institutions. When the patients excrete these bodily fluids like urine, and the urine is collected and being recycled, or the contrast media is removed from these urine samples without even being mixed in the sanitary systems of the hospitals or the municipalities. But these are at a very early stage. The one that is being established and used in a productive manner is to collect unused portions of ionated contrast media and have these shipped back to the factory to be reused or recycled. Unfortunately, this is only available in certain European countries. I don't know when this might be effective in Africa or in Kenya, but if and when this becomes available, I'm sure that my colleague Sydney will inform the societies that this has become available. I hope that answers the question.
Okay, any other question? Oguna, you have a question?
Yes,
come and speak here. You come and speak from this side. There's one more question for you.
I have to come over here.
The speaker is here.
Oh, the speaker is here. Thank you. My name is Oguna, and I wanted to ask GE probably the measures you have put in place to ensure that counterfeit contrast or contaminated contrast does not get into the patients. And I'm speaking this as a victim.
Yeah, so this is a very important point, and I'd like to thank you for bringing this up. The best way of preventing counterfeit or adulterated products is to use or purchase the products through the approved distributors in the countries. So as you know, there is an important parallel import system in many African countries. We see very strange distribution of products coming from other countries and other continents. So I was surprised to see in Africa products that were intended for the Korean market. So just imagine that the product is being manufactured in Europe, shipped out to Korea, and then it's being reshipped to Kenya or other African countries through unapproved logistic methods. So the best way of preventing this is to preserve your well-being and your safety, your legal and ethical safety, and your patient's well-being through the usage of approved distributors. So our distributors in Kenya will make sure to provide you with products that are safe and have the adequate insurances that are provided by both GE and themselves. But if you purchase from unapproved suppliers, then we can no longer guarantee that you are receiving genuine products or products that have been shipped and stored in the adequate conditions, because extreme heat changes and exposure to sunlight and exposure to radiation sources can have all a negative impact on the quality and safety of the product. So the best way, once again, I would like to emphasize this, is to purchase through the approved legal distributors. So that's the most important point I can make.
Any further question? There's no more questions. So, Daktari, we thank you for having your time to do the presentation. Anyone with any further question can redirect it to our GE representatives as we finish up with this session. Mr. Commander, we also appreciate you for the good work you've done, your presentation. You did not have to ask for it. I was going to do it at this point. All the presenters, good work, and we encourage everyone to continue learning and do the presentations and research so that we keep making our field rich. At this point, I think it's the time to go for lunch. We need to break for lunch, and would want to squeeze the program a bit so that we don't leave too late. So we'll take around 45 minutes for lunch. Sydney, how long? We come back at 2. So we've all agreed that we come back at 2. Where are we having our lunch?
I think Oscar. So, of course, I saw I will be bringing some milk. So, at the lunch, I think because they are not sent in here, they have not sent here, we are going to the upper side.
So maybe you follow Sydney or Witty or Oscar, wherever there's step, you'll find lunch.
But I saw him with a bunch of milk.
Can we appreciate Senior Mjoni for coming? A good advice. I think when we step out, sometimes we we engage a lot and then we scatter. So for us to get everybody, I think we need to do a group photo. We can do it here so that we capture everybody. Sometimes people miss out. And then we'll pray for food. Once we are done with the photo, we'll tell you where to take our lunch. So please, I ask all of us to step forward. We'll do a group photo. In the meantime, let's pray. Father, in the name of Jesus, we want to thank you for the meals that are before us. We pray that you bless and sanctify. In Jesus' name we pray. So everybody step forward so that we have a group photo. By the time we are done, we shall be knowing where to take our lunch.
So, Dr. Olaji, you can hear us. Are you able to put a G logo in your screen? So we get a group photo. When you also log in, and on the top of the screen, as you get the photo. Are you able to hear me?
Anasema wapi G?
Wapi Dr. Olaji, are you able to hear me?
Kibet, saidiana hapa. Oh, good.
amenishinda.
Sijaanza kwenda chini.
Onyanga amenishinda.
Sure. You are taller than me. I thought on qualification of renewable energy.
Sio peke yake kuweza sasa tubaki.
Cameraman utupange.
Vuta kwanza.
Position yourself.
The longest.
A shot like me can stand in front.
You stand here. Seniors to sit,
Tupeleke mbele.
Please sit, Mami.
Tupeleke mbele.
Thank you.
Joet.
And make sure that as you step out, make sure that your name, your sign against your name, make sure that the numbers that is appearing there are the number stories.
These people are not listening to what you are saying.
Attention, please. Attention. Attention. You're listening to me? Hello. Martin. Those who are blessed with good height, they step please listen to what I'm saying. Make sure, everybody, you are listening to me?
Yes.
Make sure that you sign against your name on the attendance sheet and confirm that the number that is written on that sheet is the number that is registered under your name.
Registered where?
An M-Pesa. It's an M-Pesa registered number. On the song registration form. Make sure that you sign against your name and the M-Pesa number is
Okay, we need two more people seated.